common drugs that are being used in the treatment of psoriasis. So treatment of psoriasis is very, very interesting, and it has got a lot of experience, lot of understanding about the disease, and clear understanding about the drugs and its indications. So I have divided the topics as topical therapy and systemic therapy. In topical therapy, we are having an faculty, Prof.Dr. Adikrishnan. He is from SRMC, Porur, Chennai. He is a eminent teacher, and he has got a lot of experience. And he has been an external examiner for Andhra, Telangana, Kerala, and Manipal. He will be talking on the topical therapy of psoriasis. Over to you, Dr. Adikrishnan.
Thank you, sir. Thank you, sir.
Okay.
Yes, sir.
Okay.
Good morning, sir. Am I audible?
Yeah.
You're audible, doctor.
Yeah.
Thanks for the opportunity given, sir. Right answer. The topic is topical treatments of available in the management of psoriasis. Psoriasis, as we all know, just I have compared the normal healthy skin with the psoriatic skin. We have a hyperproliferative disorder. Psoriasis, as we all know, that it is a hyperproliferative disorder. We need to make sure that the hyperproliferation is brought back to normalcy. That is cell cycle time from 30 to, usually it is 30 to 32 days. It gets reduced to around 7 to 10 days in case of psoriasis. So the main aim of treatment, the topical management aims to reduce the hyperproliferation component and then the inflammation component. So the goals of treatment, irrespective of topical, special treatment, or the conventional immunomodulators or the biological, the aim is to reduce the PASI score to 75% or the 90% from the baseline, or the PASI is less than 3 from the baseline. And then to maintain the remission. Along with this, we have to reassure the patient about the nature of the disease, as well as the emotional support has to be given to the patient as well as the family members. Because this is an autoimmune disease, as we all know that it is not curable, only controllable. You need to bring them to this line as well as the family members, as how we treat diabetes, hypertension, hypothyroidism. This is also one among the metabolic syndrome. Then the cognitive behavioral therapy, treat the comorbidities. Now we say that it is mirror to many of the underlying comorbid conditions like diabetes, hypothyroidism, then the dyslipidemia, early onset dyslipidemia. All these things have to be educated, and then it may be a marker to pick this up, all these conditions at the earliest onset. Lifestyle and behavioral modification, because we have seen patients, obese patients being with psoriasis has been asked to reduce who has reduced reasonable weight in a period of time, has seen a great improvement in psoriasis. And then coming to the habit, smoking and alcohol has to be reduced, or the patient has to abstain from these behaviors so that to have a better treatment outcome, because most of the drugs which we use can also have an interaction with these behavior. As we all know, the schematic representation for the treatment of psoriasis, we have the topical preparation, then the special treatments like UV, PUA, and UVB, then comes the biologicals. As the efficacy of the drug increases, also the side effects increases, because it targets certain inflammatory mediators or the cytokines. Those have to be targeted to get the better efficacy. Whenever those are targeted, the related side effects comes along with that. So whenever we say a safe drug, always I have the question of its efficacy. Sorry. Coming to the topical which we use in psoriasis, which is my topic today, mainstay of treatment for psoriasis of limited extent, mild to moderate. Even in some type of moderate psoriasis, we stick with the topicals because of the other comorbid conditions, or the age of the patients, or the marriage status of the patient, or the childbearing. All these things are taken into account when we decide whether we are going to use the topicals or systemic or biological. When it comes to more extensive psoriasis also, certain areas may require a targeted topical therapy. Even though you use a systemic immunomodulators or biological, certain areas will be resistant to these, and we may also add on with the topical therapy for those areas. The first and foremost is your emollients and moisturizers. Emollients and moisturizers. Emollient not only reduces the scaling. Once it reduces the scaling, it also increases the moisture content in the skin, so that it limits or reduces the painful fissuring, and also controls the pruritus, which is not a major feature associated with psoriasis, but also has these emollients, topical emollients and moisturizer also has a role to reduce pruritus. And it increases the lipid content of the skin, increases the hydration, as well as maintains the hydration of the stratum corneum for relatively a longer time if a proper moisturizer is being chosen, and it reduces the Kubnerization. When the stratum corneum is kept moist, humid, and hydrated, the Kubnerization phenomenon is being reduced. That itself brings down the activity of the psoriasis. It should be usually, we just write the emollients and then we should educate the patients, the mode of applications, and then the nature of application. So ideally, it has to be applied immediately after bathing so that the absorption is better. Then comes the topical corticosteroids. So mild to moderate steroids are usually preferred for the lesions over the face, neck, flexures, genitalia, and for the unstable erythrodermic and generalized pustular psoriasis, the topical steroids has to be generally mild, has to be used with caution. Whereas the potent to very potent steroids are being restricted to use only for the thick scalp plaques and plaques over the knuckles, elbows, as well as over the palms and soles. These are all certain resistant areas where we have to use the potent to very potent topical corticosteroids. Then comes the intralesional steroids, which I told the same areas, resistant plaques present over the back of the hands, knuckles, and also for the integuments, psoriasis of the nails. We inject the intralesional steroids into the plaques. Advantages of a topical steroids when it compared to other topical agents which are available, like your topical diethrenol, coal tar, calcipotriol, the irritation potential is relatively less, but we also see certain topical corticosteroids because of its vehicle use sometimes get a erythema around the lesions because of the irritant potential of the molecule. Use it with caution, but it is very relatively less compared to other steroids, and it doesn't stain the clots. It is not messy. Usually the patient tolerates better than the other combination of topical agents, because if there is a fissuring, when you use a topical calcitriol or topical retinoids or topical steroid with salicylic, combination of salicylic, because of the fissuring, it can expose the underlying raw areas and there can be a severe irritation and burning sensation. Disadvantages, as we all know, when we use it for a longer period of time, the molecule can become very resistant, or it may not work better because of the underlying phenomenon called tachyphylaxis. And when it is applied in and around the lesions, inadvertently used, not used properly, you can get an atrophy of the lesion. And when you suddenly stop it, the two potency is there. When you use the potent, you bring down to moderate, then mild potent, then taper it, and then stop it. If there is a sudden stoppage of usage of even topical corticosteroids, we get the rebound flare of the disease. Also, it can precipitate what is called as a pustular psoriasis. And when it is used for a longer period of time, it can also cause topical corticosteroids, can also cause HPA axis suppression, which should also be taken into account. Then comes the vitamin D analogs. Now it is available in the market. We have calcitriol 3 micrograms per gram, calcipotriol 50 micrograms per gram, and then tacalcitol 4 micrograms per gram. I don't think we have the third option. The other two are available in the market. Mechanism like topical steroids, this can also causes receptor-mediated effects on the proliferation and differentiation of the keratinocytes, and also it keeps the skin immunocytes calm. And it shifts the Th1 cytokine profile to in the plaques to Th2 cytokine profile, which is an important action for topical vitamin D analogs. Advantages: it enhances the efficacy of narrowband UVB when it is used along with calcipotriol, but it should not be used at the same time. You are using a topical calcipotriol, give a gap and then start the narrowband UVB therapy, because when it is used along with that at the same time or immediately prior or after the phototherapy, it causes irritation. Disadvantages: the topical calcipotriol or vitamin D analogs, if it is abused or overused, it can cause hypercalcemia and hypercalciuria, and it can cause severe irritation, and it is applied over the flexural, facial, or the exposed areas, and then the patient goes out. Then he can develop what is called as a severe photosensitivity, and he can also lead on to phototoxicity. Word of caution: it should be applied less than 100 grams or 50 grams per meter square per week. It should not be over applied because of the systemic absorption. Its effect on the calcium metabolism has to be thought into account. Then comes the diethrenol. It's a synthetic derivative of chrysorobin, anti-proliferative, pro-apoptotic effects on the keratinocytes. It also has it inhibits neutrophil chemotaxis and leukocyte migration. It is closely used with UVB in grams regimen. In our institution, we don't use this gram regimen, but we do use a short contact diethrenol. In the market, what we have is a diethrenol along with the coal tar preparation is available, along with salicylic acid. So it's always better to use it as a short contact therapy over than for a longer period of time, because the irritant potential is very severe and it causes also discoloration of the skin. So it has to be used with caution. It should not be painted over the normal areas around the lesion. Exact care and then the advice. Actually, the first application has to be done under the supervision of a doctor and then explained to the patient, and it has to be prescribed to patient who can well absorb the detail of these preparation. Contraindication: it should never be used for the soft skin, flexural skin, or an erythrodermic psoriasis, or an angry looking lesion adjacent to the lesion which you are selecting to apply, and even for the pustular or unstable psoriasis. Then coming to the topical retinoids, topical Tazaratin, now it is available in the market. That also we use it as a short contact therapy before proceeding to a long-time application. It also reduces the epidermal cell proliferation, inhibits psoriasis associated differentiation of the keratinocytes. Now we have an advantage of topical Tazaratin with mometasone available in the market, which also reduces the irritation potential of the Tazaratin, which usually we get. So we may be little not in favor of using Tazaratin because of the irritation potential. Now, from a well-known brand, it is available with a combination of mometasone. I have been using for some certain thick plaques over the palms and soles. In the instep, even after using your conventional immunomodulator for a longer period of time, we see some plaques remaining in the instep or a simple plaque in the retroauricular area. They remain for a longer period of time. In those things, in those areas, we can give a try of this topical Tazaratin with steroid combination, which works well. And this molecule can also cause irritation. Should be very careful. And this topical Tazaratin gel can also be used for nail psoriasis. The way I use it, you apply the Tazaratin for the affected nails. We use a micropore tape so that we use it like how we use steroid under occlusion. Even a Tazaratin under occlusion, I have tried. It gives better results than using just plain Tazaratin alone. And we can also use the combination of Tazaratin with the mometasone over the nail psoriasis. It gives better results. But we need to be very careful when we do the occlusion or when we apply it over the nails. You don't damage the proximal nail fold, because by damaging the we applying over the proximal nail fold, we damage the cuticle, and then we always land up in recurrent paronychias over the course of time when we use this molecule. So care has to be taken not to use it very close to the proximal nail fold, whereas to the distal nail plate, it can be safely used. In the nail also, start with a short contact, then you can for the overnight application if the patient tolerates. Then the time-old keratolytic agent, salicylic acid, even though we don't use it as a single agent, we combine it with a steroid or a moisturizer or a urea containing.
Speaker, sir, kindly unmute yourself, sir. Dr. Adikrishnan, sir, kindly unmute yourself, sir. Speaker, sir. Dr. Adikrishnan, sir, kindly unmute yourself, sir. Yes, sir.
Okay, am I audible?
Yes, sir. Audible, sir.
Yeah. Then comes the salicylic acid, which is a time tested, which we use the salicylic acid molecule. We don't use it as a single agent. We combine it with a moisturizer, urea containing moisturizer, or a glycolic acid containing moisturizer, and also with a steroid to enhance the penetration of the active drug into the plaque of psoriasis. We use it for the palmoplantar lesions. We use it for the scalp lesions. We use it for the lesions over the knuckles and knees. It gives excellent result when it is combined with steroid. The efficacy of the steroid is also increased, but you need to be careful. You don't use it for the extensive areas. For example, more than 10% of the body surface area. Do try to avoid using a salicylic acid preparation because it can cause irritation, burning, even salicylism over a long period of time. Then comes the coal tar. Coal tar in combination with UVR that is mainly UVB, is very well known regimen for psoriasis known as the Gokerman regimen. We also have a modified Gokerman regimen. We use it 5 days a week. We apply the coal tar for 5 hours, then exposure to narrowband UVB. Depending upon the tolerance by the patient, we tailor the dose. Then the topical calcineurin inhibitors, which is a major boon in the past 1 decade. We have the topical tacrolimus and pimecrolimus, which is very safe. That pimecrolimus can be used as young as more than 2 years of age. Some people say even after 6 months of age it can be used. Tacrolimus, we use it from more than 6 years of age. We gives better results. Certain areas where we cannot use steroids or a calcipotriol, diethrenol, or a salicylic acid, like the flexural areas, facial areas, and then the facial psoriasis in children and the genital areas, even though we do encounter it rarely, it is one of the non-venereal genital dermatosis that too nowadays we come across in patients, elderly patients who are diabetic. They complain of itching. When we clearly examine, we see the scaly plaques over the genitals, the shaft of the penis, pubic areas. Even we have biopsy proven those to be characteristic of psoriasis. In such areas, calcineurin inhibitors can be used, but has to be used with caution. Even though the Western literature says that it is the drug of choice for the facial lesions, flexural lesions, in our down south population, what we have seen, when we apply this tacrolimus or pimecrolimus, it also produces severe irritation. We then immediately tend to combine it with steroids. We use it as a short-term therapy or alternate it with the moisturizer. That's what happened. Most of the patients do not bear the irritation associated with tacrolimus as with the Western population. That's what my experience with tacrolimus. I do use it, but use it with caution. Topical methotrexate gel in different formulation has come into market. It was even introduced in the early 2000, but was not a successful molecule. Now it has come with a larocaprum gel formulation, lipo gel formulation. So we use it for thick plaques. It has got a severe irritation. So it has also to be tried. Started with a short-term application, weekly, twice or thrice a day application. Then if the patient can tolerate the molecule, can be daily applied. And then immediately it can be combined with the topical steroids also. I use this topical methotrexate gel, which has now recently come into the market in the liposomal formulation for the nail psoriasis, which does better. Weekly, twice application under occlusion. I use it for a short contact and then ask the patient to wash it off over a period of time. It has given excellent results. There are reports of using this methotrexate as an intralesional injection at both the sides of the angles of the proximal nail fold. And the problem what we usually face with these intralesional anti-mitotic agents is severe burning, necrosis, pigmentation, residual hyperpigmentation, which we use like bleomycin, 5-fluorouracil for the plaques of that is hypertrophic scar or the keloids. We have the severe burning and then the necrosis, hyperpigmentation, which is a very, very, very bad side effect from the patient side of you. So we are skeptical in using this. Among the anti-mitotics, I have seen this methotrexate to be relatively well-tolerated anti-mitotic in the management when it is used intralesionally. I don't deny that it is totally free. There is an irritation, there is a pain during injection, but relatively better compared to the other anti-mitotics. Topical JAK-STAT inhibitors, like we are using it now orally. Now the topical are also in the pipeline. Your topical Tofacitinib, Ruxolitinib, and Baricitinib are under phase 2 trials. They block the intracellular signal pathway by blocking the gene transcription of the crucial pro-inflammatory cytokines, which play a central role in the etiopathogenesis of psoriasis. So when it comes, we have another armor in our management, along with the steroids, topical, vitamin D3 analogs, and then topical antimitotics. This will also join the bandwagon in the management of psoriasis. Topical phosphodiesterase 4 inhibitors, along with their oral PDE4 inhibitors. This has also got a role in psoriasis. That too, the roflumilast 0.3% cream is being approved by FDA in 2022 for the plaque psoriasis, is now available in America. I shortly expected in India. We might use this for a lot of other papillosquamous disorders other than plaque psoriasis, and it is being approved for patients aged 12 years and above. So it can be used in over areas where it is very resistant. It goes well with the steroid preparations. There are studies comparing it with the topical steroid salicylic with the roflumilast combination that give comparable results. The first topical phosphodiesterase E4 inhibitor approved for the use in psoriasis. Then the off-label use of crisaborole, which were used for the management of atopic dermatitis, has also got a role in the management of flexural and facial psoriasis. It has also not been available in India. I think we are expecting it to be shortly coming to Indian market. Topical fumaric acid esters, monoethyl fumaric acid esters, 1% and 3% in an ointment or as a bathing oils have been used. It can be used with oral fumaric acid esters. These fumaric acid esters in the management of psoriasis more published from the European literature than from the Indian literature in moderate to severe psoriasis, and even they have got a role in nail psoriasis. It inhibits the expression of pro-inflammatory cytokines, interferon, TNF alpha, interleukin 8 and interleukin 1b. As with any keratolytic agents or any agent which dilutes the intercellular adhesion, it can also cause irritation. Skin flushing to be noted for the topical fumaric acid esters over a long period of time, larger areas. Skin flushing is one of the important side effects associated with topical fumaric acid esters. Then intralesional corticosteroid injection, triamcinolone hexacetonide 5 mg per ml or acetonide 10 mg per ml. The technique: do not inject closely, give a gap of 1 to 5 millimeter between the injection. Usually inject it at the periphery, reserve it at the center at the last. Infiltrated intradermally into the localized plaque, over the shin plaque or the knee plaque, which is resistant even after a long-term topical therapy or systemic therapy. We try this method. Effect is long lasting for several months. Be careful when we use it in elderly patients who are diabetic, because there can be ulceration, flare-up of furuncles and folliculitis in and around the regions. So intramatrical methotrexate, which I have touched upon previously itself, in methotrexate 2.5 milligram injected into each side of the proximal nail fold. It is usually once a week for 6 weeks, but we tend to see the result even from the second week itself. Tolerable pain. I don't say there is no pain. There is a tolerable pain. Nail changes improve. No clinical or laboratory side effects noted after 8 weeks of intramatricial injection of methotrexate. Not a long-term side effects or not a long-term damage to the nail plate after the nail matrix injection has been noted with the methotrexate. The Porur UVB therapy might be even taken up by the next speaker when they talk about the systemic therapy. I am also putting a slide on that. It is when the conventional topical corticosteroids or the topical therapy doesn't have a major effect in the management, we go to the next therapy, that is a UVB therapy. When generalized psoriasis unresponsive to topicals, the next line in the management or the ladder is your UVB phototherapy. Narrowband UVB is considered to be more effective than the broadband UVB, and it is a part of your Gokerman as well as the Ingram regimens. Mechanism of action of your phototherapy: cutaneous immunomodulation by increasing the vitamin D and inducing the apoptosis of the T cells and the keratinocytes. Reduces the epidermal hyperproliferation. These are all the 3 pathogenetic mechanisms which is targeted by the UVB phototherapy. Dosage based on either the Fitzpatrick skin types or the minimal erythema dose. Minimal erythema dose is nothing but the minimal amount of ultraviolet energy required to produce a visually perceptible erythema. Determine the MED first, and the initial treatment is with 40 to 50% of the MED. For the first 1 to 10 treatments, first 1 to 10 treatments, we go by 5 to 10% increase of the initial MED. Even within this 5 to 10 treatments, if there is erythema, you stick to the same MED or same dose or reduce it by 10%. More than 21st treatment increase depending upon the physician scoring, or the physician who treats it, he decides upon the increment of the dose. UVB therapy, we go with 3 times a week. What are the adverse effects commonly noted? Erythema, pruritus, and blisters, but it is less common compared to the UVA therapy. Cutaneous carcinogenesis also is less common compared to PUA therapy. We have to protect the eye, scrotum, and the genital skin from the irradiation, as with any phototherapy protocol. Avoided in patients taking cyclosporine due to the accelerated rate of cutaneous carcinogenesis. Cyclosporine also has got a greater effect on the T cells, and most of the T cell mediated diseases, we tend to choose cyclosporine. So whenever we try to switch it to phototherapy, we need to be very careful because of the cumulative toxicity both the things produces it. Psoralen Photochemotherapy, that is coming to the PUA. Psoralen is a drug which we give it orally, and then after 2 hours, we expose it to the UVA therapy. The mechanism of action, the Psoralen binds to DNA, and when it is exposed to UVA, it produces what is called as photoadducts. This causes permanent DNA damage and this resulting in the cell death. So that this causes keratinocyte hyperproliferation is being reduced, decreases the antigen presenting Langerhans cells in the dermis, and then reduces the angiogenesis. That is also one of the important event in the psoriasis, where the squirting papillae and then the squirting of lymphocytes through the civet canals is one of the immunopathogenesis in the pathogenesis of psoriasis. So the PUA therapy has got a role in reducing the angiogenesis, causes T cell apoptosis associated with clearance and remission of psoriasis. The common psoralens are used is 8-methoxy-psoralen, 5-methoxy-psoralen. These are all the two things which we commonly use for psoriasis, 0.6 milligram per kg body weight, and then we have it as 10 milligram tablets. Trioxypsoralen or trimethylpsoralen, which we usually commonly use for the depigmentary disorder, that is a vitiligo. Psoralens can also be either used topically or orally in combination with UVA. Dosage: 8-methoxypsoralen is usually given at a dose of 0.6 milligram per kg 2 hours prior to the UVA therapy. The initial dose of UVA is calculated as 70% of the phototoxic dose, MPD. When we call for UVB, we call it as a minimal erythema dose. Here we call it as minimal phototoxic dose. That is a difference when we calculate the exposure for UVA. 20% increments are given until the erythema occurs. There we use it 10% increments, because PUA, that is UVA, has got more penetration potential, whereas UVB has got more erythema potential. So that the dosing and then the increments will be slightly more for UVA compared to UVB. PUA is usually given as twice weekly treatment. PUA may be combined effectively with oral retinoids, what we call it as re-PUA. We don't combine cyclosporine, but we safely combine oral retinoids, because the retinoids reduces the cumulative dose of UVA and also in turn reduces the carcinogenesis in long term. Oral retinoids dose also, required dose to cause remission of psoriasis also reduced when we combine it with PUA. So a synergistic activity, cumulative dose is reduced, so the cumulative toxicity is also reduced. That is the idea of combining two drugs when you treat a long-term morbid diseases. Side effects: erythema, blistering, and a severe pruritus, which doesn't respond to your just antihistamines. We call it as a neurogenic pruritus. Then the non-melanoma skin cancer, basal cell carcinoma, and squamous cell carcinoma are the common long-term side effects, which when we do it without following the protocol. And one dictum, a cutoff value, what we should keep is patients who tolerates PUA, who carries on with the PUA treatment, do not exceed beyond 200 treatments of PUA. Those are all the group of patients who go in for this non-melanoma skin cancer. And then as for the postgraduates, what are all the common specific side effects of PUA therapy in the skin? Nausea, vomiting, dyspepsia, all those things. Other than that, because of the PUA, what we get is hyperpigmentation, PUA lentigenes, hypertrichosis, lichen planus, bullous pemphigoid, granuloma annulare, and then comes your PUA lentigenes. These are all some of the common cutaneous side effects which we expect from the candidate when we ask what are all the side effects associated with PUA. Cataract. So only we specially prescribe certain specific glasses when the patient is sent into the PUA chamber. What we call it as Crookes toric glasses, which are specific glasses which they give along with the instrument itself nowadays to prevent the PUA induced cataracts. Teratogenicity has to be explained. So only we don't use PUA therapy below 18 years and in the pregnant woman. Relative contraindication, as I told earlier, it is along with cyclosporine to be thought of, should not to be avoided, to consider other immunomodulators along with PUA. Climatic therapy, which is the Dead Sea region. It is 400 meters below the sea level. So mechanism in that area, the evaporation forms an aerosol which filters the majority of UVB and not majority of UVA. So it has got a specific pattern of electromagnetic spectrum in that area. That mixture of sunlight clears psoriasis without sunburn. That is the thing which has to be taken into account. Here, the patient has to stay in that light for 3 to 4 weeks, which we get excellent results. This is what we call it as a Dead Sea therapy or climatotherapy related to psoriasis. And then the targeted phototherapy. Now, what we talk of excimer lasers, not many of us have the opportunity to use because of the exorbitant cost and then the affordability of the patient to use or afford to these treatments. But it has made a major role in the management of psoriasis and vitiligo. Excimer laser is a 308 nanometer monochromatic. Whichever is monochromatic or controlled lasers have got an excellent result because it can have a better delivery. And here we use a supra-erythmogenic doses of light up to 4 to 6 MED. That is a basic mechanism by which it works. It gives more of MED. And other targeted phototherapies, we use less than the MED. Here we use like a pulse therapy, we use up to 6 MEDs. We concentrate focally to the lesional skin. Treatment is usually given twice weekly. Adverse reaction, as with any phototherapy, here you have erythema, blistering, hyperpigmentations, erosions, and long-term side effects similar to narrowband UVB. Absolute coexistent photosensitive disorders and connective tissue disorders, because most of the connective tissue disorders presenting to skin are photoexacerbated disorders. The relative contraindications, photosensitizing medications, even oral and topical medications, melanoma and non-melanoma skin cancers. Always be careful not to use these phototherapies or targeted laser therapies. Then comes the Balneophototherapy. Here, a saline bath, but at a 20% concentration of normal saline, that is sodium chloride. The patient is soaked for about 15 minutes at room temperature and then irradiate immediately after the bath with UVB. Here, what it does is the mechanism saline solution changes the optical property of the stratum corneum so that the MED gets reduced, so that we irradiate at the room temperature itself, and then it elutes the pro-inflammatory mediators or the cytokines from the stratum corneum, which is responsible for the pathogenic cascade in psoriasis, which causes the hyperproliferation. Then the magnesium ions as a part of this saline also causes a functional perturbation as well as depletion of epidermal Langerhans cells, which is nothing but the antigen presenting cells in the psoriatic skin. Thank you. I have tried to cover up the topical therapy which I have been using other than this balneotherapy and then the Dead Sea therapy, which I have been other the topical preparations and the phototherapies which I have been using in my practice in day-to-day practice. So if I had missed out certain topical therapies, I apologize for that. And I would like to put up some multiple choice questions for the postgraduates perspective. Can I go ahead with that, sir? Or at the end of
Yes. You go ahead.
Thank you, sir.
Once the 1 second. So once the questions are posted, we'll give 1 minute time, 30 seconds time. You can you can post your answers in the chat box. Thank you so much.
First question: which one of the following is an indication for the intralesional steroids in psoriasis? The indication. It can occur in any type, but the indication. Choice A, nail psoriasis. Choice B, scalp psoriasis. Choice C, inverse psoriasis. Choice D, guttate psoriasis.
Yes, sir, you can shoot second questions.
Question 2. Which of the topical agent is preferred in treating facial and flexural lesions? A, corticosteroids. B, calcineurin inhibitors. C, calcipotriol. D, Tazaratin.
Yes, sir. Third question.
The third question, what is the maximum number of PUA treatment a patient can receive? A 150, B 200, C 250, D 300.
Yes, doctor.
Question 4. Gokerman regimen combines ultraviolet radiation with which of the following topicals? A. Diethranol, B. Salicylic acid, C. Coal tar, D. Psoralens.
Yes, doctor. All this.
Yeah.
This is the last question. Which of the following is the latest FDA approved therapy for psoriasis? A. Ruxolitinib, B. Rofecoxib, C. Romiplastim, D. Roflumilast. Thank you.
Thank you, Dr. Adikrishnan.
Thank you,
It
sir.
is very nice presentation. And I think most of the postgraduates will be benefited from your presentation. You have given the drug in detail as well as the method of use of the drug and the indication. That is very good. And I think the postgraduate should follow what Dr. Adikrishnan has been telling to you. And in your future practice also, this may be a guideline for patient care. Thank you, Dr. Adikrishnan, for
You,
your
sir.
excellent talk.
Thank you, sir.
We'll
Thank
meet,
you for the
we
opportunity.
will meet sometime back.
Yes, sir. Definitely, sir.
From here.
Thank you.
Okay, thank you. Thank you, Adikrishnan. Now, I think Dr. Devi is ready. Okay. My pleasure to introduce Dr. Devi. Dr. Devi is right now is professor of dermatology in Calicut Medical College. He has worked in Trichy Medical College and then
Is the screen visible?
Screen is not visible.
No, ma'am. Screen is not visible, ma'am.
The first marathon together.
Yeah, it is now visible.
Yes, madam. Visible.
Okay. Good afternoon to all. So first of all, I thank Kaitan sir for giving me this invitation to talk in this session. I think I'm audible.
Yeah, it is audible.
So today, after an interesting session on the topical treatment of psoriasis, now we'll be considering the systemic treatment of psoriasis. Systemic treatment is an extensive topic. Out of this, I'll be confining myself to the conventional treatment. So psoriasis, as all of you know, is a chronic inflammatory skin disease with a well-demarcated scaly plaques on the extensor as the typical sites involved. And the disease, previously we thought that it is a disease mainly affecting the keratinocytes and inflammation and proliferation of keratinocytes. But later on, now we know that it is a complex interaction of the T cells, cutaneous T cells, dendritic cells, and keratinocytes. There is a liberation of so many cytokines and soluble mediators involved. And this process leads to the keratinocyte proliferation, which manifests as the characteristic scaly plaques. And this inflammation, this inflammatory process augments inflammation, which is involved in the metabolic syndrome, cardiovascular diseases, and arthritis, which are the other associated diseases of psoriasis. Now, to inhibit this inflammatory process, we have so many topical and systemic medications created for this purpose. The fact that we have so many preparations for it itself shows that there is no single answer for the problem. So we should know the disease process. It can vary from a very small invisible plaque on the scalp or elbow, or it can extend up to an extensive exfoliative dermatitis, and so much variations can occur. And the aim of our treatment is to control the disease, keep it under control with minimum adverse effects. So that is the aim of our treatment of psoriasis. So when should we go for systemic treatment in psoriasis? Previously, the guideline was to start systemic treatment if the body surface area is more than 10%, PASI more than 10%, and DLQI, quality of life index, if it is more than 10%, that was a guideline. But nowadays that there is a slight change in the guideline, which says that the body surface area is more than 10%, but certain other aspects are also included in that. When there is involvement of special areas like visible areas, scalp involvement, genitalia involvement, dystrophy of the nails, all these are included as indication for systemic therapy, along with failure of topical therapy. The thing is that this is only a guideline. So we can decide depending on the requirement of the patient and his other personal characteristics, we can decide. This is only a guideline, and these additions are given in order to this addition of indications for systemic is given a little more freedom for us to give systemic treatment. Now, the drugs, there is a wide range of drugs available nowadays for the treatment of psoriasis, varying from broadly we can classify as non-biological drugs and biologics. Non-biologics, conventionally used ones and small molecules, and the biologics. And it is generally said that the advent of biologics has revolutionized the treatment of psoriasis. But still then there is a definite role of conventionally used drugs in the treatment of systemic treatment of psoriasis. The drug rapidity of onset of action of the drug. Certain drugs act very slowly. For example, Acitretin will have there's a long period for onset of action, whereas Cyclosporine starts action very early. Like that, the rapidity onset of action of drug is one fact. Individual factors, comorbidities of the patient, obesity, the presence of arthritis, inflammatory bowel disease, associated infections, and other systemic diseases. All factors are to be considered before deciding on which drug is to be started. So in order to do that, we should have a detailed awareness of the advantages, disadvantages, toxicities, and all principles of these drugs. So first, let us start with the drug, the age-old, which was approved for use in psoriasis by FDA in 1972. So that we have experience of about more than 5 decades with the use of methotrexate. Does it act? So methotrexate acts over the folic acid metabolism, so that it blocks the formation of DNA and cell multiplication. It acts on dihydrofolate reductase as well as thymidylate synthetase. Both are in the folic acid metabolism. So because of this DNA inhibitory effect on DNA multiplication, there is anti-proliferative effect on keratinocytes. Previously, we used to think that this was the only mechanism of action of methotrexate, but now we know that this effect is there on the lymphocytes also. It prevents multiplication, it prevents inhibition of apoptosis of lymphocytes, so there is an inhibitory effect on lymphocytes. And because of the effect of lymphocytes, there is immunosuppressive effect for the methotrexate. Again, the methotrexate, the intracellular metabolite of methotrexate, that is polyglutamate derivatives, inhibits ICAR transformase. This effect on this enzyme causes an accumulation of adenosine inside the cells, and this adenosine has got anti-inflammatory property. So these are the mechanisms of methotrexate. So we know about methotrexate, so we should know when to start methotrexate, which are the indications, or when we have to think of methotrexate in a patient with psoriasis. It is an effective drug in erythrodermic psoriasis, pustular psoriasis, psoriatic arthritis, and extensive plaque type psoriasis. And often in plaque type psoriasis, we may consider PUA therapy and topical therapy, and when that fails also, we will be thinking of methotrexate. So if you think of methotrexate, and if there is a indication for methotrexate, we should know what are the contraindications, when it should be avoided, absolutely. So this is the situation when there is a hypersensitivity to the drug, if there is pregnancy or breastfeeding, if there is severe chronic liver disease due to alcoholism, previous blood, if the patient is having blood dysplasias, or if there is an immunodeficiency state. All these states are absolute contraindications. You have to think of alternative drug. But suppose we can start, there are no absolute contraindication, then we can think of methotrexate and which should start. The usual dose that we do is 7.5 to 25 milligram weekly dose. You can give a single, can give in 3 divided doses. All are equally effective. 3 divided doses often reduces the gastric disturbances. You can give orally, subcutaneously, or IM. There is no inferiority or superiority of these different routes proved, but it's said that subcutaneous or IM routes increases. There is complete absorption. Absorption is much more clear with subcutaneous or IM. So we may sometimes choose for parenteral route if there is gastric irritation. With severe gastric irritation, you can go for parenteral route. A test dose, sometimes we give a test dose of methotrexate to start with, that is 2.5 or 5 milligram given, followed by a blood count test 5 to 7 days later. This is mainly to avoid pancytopenia. Some people can develop pancytopenia even with a single dose of methotrexate, and it can be life-threatening. So you may go for a test dose, especially if there is an underlying risk factor for pancytopenia, like if there is a underlying renal disease, or if there is a chance of drug reaction. In that case, we have to give a single test dose. And if there is not much risk, even you can even start a single dose, 7.5 to 15 milligram. The whole dose can be started, and the methotrexate dose then can be adjusted depending on the response of the patient. Usually, we have to wait about a month time for the effect of the particular dose of methotrexate to be known. Concomitant supplementation of folic acid. Usually we give 1 to 5 milligram folic acid along with the methotrexate. In the days, apart from that, we give methotrexate that reduces the gastric disturbances as well as the chance of pancytopenia. So that is usually recommended. Now, we should know the adverse effects of methotrexate. Once we start a patient on the drug, we should be knowing the adverse effects, and that helps us to monitor the patient properly. So the most important adverse effect is hepatotoxicity. As all of you know, prolonged use of methotrexate can cause fibrosis of liver, and which can later on lead on to cirrhosis. And there are few precipitate or predisposing factors for hepatotoxicity that we will consider later. Methotrexate can also cause acute pneumonitis, and on prolonged use, fibrosis of lung, even though this is less common with using psoriasis. Pancytopenia, I already described. Pancytopenia can occur, and it is a life-threatening complication, especially if there is an underlying renal disease, or if there is a chance of drug reaction, which causes increased toxicity of methotrexate. GA disturbances, as it prevents the multiplication of all rapidly multiplying cells. There can be all the mucosal cells can be affected. There can be stomatitis, nausea, vomiting, all this can occur. Lymphoma is reported with the use of methotrexate. And it is very important to know that this is a category X drug in pregnancy, cannot use in pregnancy. It is a teratogen and abortifacient. And it can cause oligospermia. It is reversible oligospermia in males, and can have teratogenicity if the person is fathering a child while using methotrexate. So when you are giving methotrexate, the patient can become pregnant only 3 months after withdrawing the drug. And the patient can father a child only 3 months after completion of the treatment, because duration of spermatogenesis is about 74 to 75 days. So that gap is required to parent a child. Renal toxicity is extremely rare. Methotrexate as such causing renal toxicity is rare. But if there is an underlying renal problem, there can be increased drug level. So that is a problem with the renal system. And we have to consider the drug interactions, which is very important case of while treating methotrexate, that we'll consider in the next slide. So a few factors which increases the hepatotoxicity in methotrexate. The conditions which can cause non-alcoholic liver disease can all have an increased predisposition to hepatotoxicity due to methotrexate. Obesity, diabetes, hyperlipidemia, all these can cause non-alcoholic liver disease. Psoriasis as such can have an associated non-alcoholic steatohepatitis. So all these are predisposing factors for hepatotoxicity. Other factors are alcohol use, persistent abnormal liver function test, presence of hepatitis B or C, prior exposure to hepatotoxic drugs, and if there is a family of history of an inheritable liver disease. All in the presence of all these factors, we have to be doubly careful while treating a patient with methotrexate. And the drugs with high risk are sulfamethoxazole, trimethoprim, dapsone. All these can interfere with the folic acid mechanism, and immunosuppressants add increased immunosuppression, cannot give live vaccines. Retinoids increases hepatotoxicity. And a few drugs which are of low risk are phenytoin, tetracycline, and NSAIDs. All these displaces methotrexate from protein binding sites. So there can be an increased level of methotrexate in the blood, but that considered to be not that severe, considered to be a low risk factor. Now, since we know all these problems that can occur with methotrexate, how do we monitor? With baseline, we have to do the CBC platelet count, LFT, screening for hepatitis B and C, RFT, HIV screening, and we have to rule underlying infections, tuberculosis especially. And about consider biopsy, consider baseline liver biopsy in high-risk patients. That is the guideline. But usually we don't go for liver biopsy in a routine practice, because it has got its own morbidity and mortality. Liver biopsy is an invasive procedure which is risky. And another factor is that there can be sampling error. Even if you take a biopsy, you may not get a site which is having abnormality. So sampling error can occur. And sometimes in a high-risk patient, you may not continue with methotrexate. You may start methotrexate, and if the patient may not tolerate methotrexate, so you will be doing unnecessarily a risky procedure. And similarly, the patient may not respond to methotrexate also. So because of these factors, sometimes we may not go for a liver biopsy at the beginning of a treatment, even in high-risk patients. Low-risk patients, you can start without doing a liver biopsy. Now, considering follow-up, the CBC platelet and LFT has to be done 5 to 6 days after the first dose, as already we have discussed. And in the first month, we have to check it every 1 to 2 weeks. And whenever you escalate the dose of methotrexate, we have to do LFT and CBC within 1 week time. And once after the 1 month, long run, you can do the CBC platelet count and LFT in every 3 to 4 months time. Liver biopsy in low risk patients is done, is advised 3.5 to 4 gram total cumulative dose. But still, now with the advent of so many non-invasive procedures, we will be briefly considering the requirement for liver biopsy has come down. Subsequent biopsies are advised. These are the guidelines: 1.5 gram cumulative dose after the initial 3.5 cumulative dose. RFTs to be done once or twice yearly. And nowadays, the advice, some people consider doing fibroscan every year. That is considered as an alternative to liver biopsy. So which are the non-invasive tests that you can do to in the place of maybe in the gold standard is said to be still liver biopsy, but which are the other non-invasive tests? Liver stiffness assessment by transient elastography. That the fibroscan is a vibration controlled transient elastography. And this is considered to be a method by which we can assess the fibrosis in the liver. And there are serological tests like fibrosis-4, which is an algorithm based on liver enzymes, platelet count, and the age of the patient. And the measurement of amino terminus of type 3 procollagen. All these are the non-invasive tests which are being more used nowadays. And along with the help of a gastroenterologist, these investigations may reduce the need for going for invasive liver biopsy. So if you are doing a liver biopsy, there is a grading 1, 2, 3A. 1, 2, 3A are mild, 3A are mild forms of changes in which you can continue with the treatment. Whereas if there is 3B and 4, that is moderate to severe fibrosis and cirrhosis, we have to stop the drug. 3A, also mild fibrosis, we have to repeat biopsy after 6 months. That is the guideline regarding liver biopsy. Now, regarding other investigations, when to stop the drug when you are monitoring the patient. The WBC found if it is less than 3,500 cells per cubic millimeter, you have to stop. Platelet count less than 1 lakh, and transaminases twice upper limit of the normal value. These are the situations we have to stop the drug. You can restart once the values become normal, and after giving a rest for 2 to 3 weeks. Then you can restart the drug. So that is in general about and most important nowadays we are, maybe in our setup, we are using more of methotrexate even now. So that is an important drug. Now coming to the next drug, which is very useful, again, very useful in psoriasis, is cyclosporine. Cyclosporine was approved in 1997. It is an immunosuppressant and it functions by binding cyclophilin, which is an intracellular protein, which inhibits the calcineurin and then blocks the inflammatory signaling. So several inflammatory mediators are suppressed, like interferon gamma and interleukin 2, and there is a suppression of T cells. So that is the mechanism of action of cyclosporine. When do you consider cyclosporine? Cyclosporine is considered when there is an acute flare-up of the disease, and when you need an immediate control of the fast control of the disease, maybe because of the nature of the disease, flare-up of the disease, or maybe the requirement of the patient, some function in the family or some occupational requirements where the patient needs an immediate control of the disease, you can go for cyclosporine. And it is effective in pustular psoriasis and psoriatic arthritis. So considering cyclosporine, first think of absolute contraindication and rule out that before starting treatment. Poor treatment, as Dr. Adikrishnan has discussed, poor treatment, especially more than 200 treatments, you cannot give cyclosporine because of added risk of malignancy. Then radiation therapy, again, you cannot give along with that. And the abnormal renal function and hypertension are there. Then also you cannot give presence of malignancy and hypersensitivity to cells. These are the situations where you will not you cannot give cyclosporine. So once you decide to start cyclosporine, what is the dosage? The usual dosage, if the disease is mild to moderate, you can start with 2.5 to 3 milligram per kilogram per day in divided doses, and gradually increase the dose 0.5 milligram per kilogram per day until you get an adequate control. Or if the disease is very severe, you can start with high dose at 5 milligram per kilogram per day, and then taper the dose once the disease is under control. The main problems with cyclosporine once we start is, one is nephrotoxicity, and then the second one is hypertension. You have to be very careful. The nephrotoxicity, if you are giving the drug for short duration, it is reversible. It is due to the constriction of arteriolar vessels. So once you stop the drug, it is reversible. Whereas on prolonged use, there can be structural changes in the renal system, and then becomes irreversible. So what we have to do is monitor the creatinine level. If it is about 25% of the baseline, in 2 separate occasions, we have to reduce the dose of the drug. 25 to 50% reduction is to be done, and then monitor the creatinine and see whether it is reducing. Even after 1 month, if it is not coming down, we have to again reduce 25 to 50% the dose. And if still not controlled after 1 month, we have to quit the drug, stop the drug. Similarly, the next problem is hypertension, again due to the renal arteriolar constriction. There will be hypertension, and usually hypertension occurs before the abnormality in the creatinine occurs, and the dose is to be reduced if there is abnormal value in 2 occasions. Cyclosporine can cause is having other adverse effects. As we know, this immunosuppression, there is a chance for malignancy, and there are less severe problems like fatigue, paresthesia, hypertrichosis, and lower threshold for seizure. All these are important, but less severe. Now, how to monitor them once we start the patient, what are the investigations to be done before starting and how to follow up. BP is to be tested on 2 occasions to rule out presence of hypertension. Blood urea nitrogen and creatinine to be tested, urine analysis to rule out tuberculosis, LFT, CBC, lipid profile, magnesium, uric acid, and pregnancy test is to be done if required. And ongoing monitoring, BP is to be recorded. Early morning resting BP is to be checked, and blood urea nitrogen and serum creatinine every other week it is to be tested, and this to be done for the first month. And if there is no persistent abnormalities, it can be done every month. And we have to do monthly CBC, LFT, lipid profile, magnesium, uric acid, and potassium. Pregnancies as required should be done. So that is briefly about cyclosporine, how to start, how to monitor, and when to withdraw the drug and how to proceed. So now coming to the third important drug that we use, very useful drug, is Acitretin. Acitretin, as all of you know, is a second generation retinoid. And this drug was approved in the year 1997. It modulates the epidermal differentiation and proliferation. It has got anti-inflammatory effect, immunomodulatory effect, and it normalizes the keratinocyte proliferation and formation of the scaly plaques. One important aspect of acitretin is that it is not having an immunosuppressive effect, unlike all other medications that we have for the treatment of psoriasis. The main indication for acitretin is it is useful in plaque psoriasis, useful in pustular psoriasis, both generalized and localized, and it is not effective. It doesn't have much effect on the psoriatic arthritis. And it is used in combination therapy also. Now, acitretin, we will be giving in a dose of 10 to 50 milligram per day. Usually, we give up to 50 milligram per day as a single dose. Lower doses are often we control the disease with 50 milligram and then reduce the dose of to lower the dose in order to reduce the adverse effects of the drug. We use this, I think, combination therapy I'll be considering later. The contraindications of acitretin, when not to use acitretin, is we have to be very careful in children, in women, in the childbearing potential. Cannot consider pregnancy up to 3 years after completion of treatment. That is because there will be conversion of acitretin to atretinate in the body. And since atretinate is highly lipid soluble, it can persist in the body for about 3 years time. So that the teratogenicity may be there up to 3 years. So pregnancy can be considered only 3 years after withdrawing the drug. And that is one important contraindication for acitretin. And it cannot be given in patients with severe liver or kidney function abnormalities, and when there is severe blood lipid abnormalities. Baseline monitoring that we do the lipid profile, CBC, LFT, and renal functions, and pregnancy test. And ongoing monitoring, LFT, lipid profile should be done once in a month for 3 months, and then every 3 months. CBC, renal function tests are to be done only in once 3 months. Pregnancy test as indicated. So once we start the patient on acitretin, the important or most common problem that they come back with is dryness. There will be dryness of the skin, mucosa. So there will be severe cheilitis, dryness of the eyes, nasal dryness causing epistaxis. So these are the complaints with which they come back. So a proper moisturization of the skin and mucosa is highly necessary when we start the patient on acitretin. And there is a chance for paronychia and pyoderma. There is a chance for increased intracranial hypertension, causes pseudo tumor, cerebral-like symptoms, headache. There can be nausea, abdominal pain, hypertriglyceridemia. Hyperlipidemia, especially hypertriglyceridemia, is an important problem when we start them on acitretin. Rarely, liver abnormalities can also occur with acitretin. And there are a few adverse effects, drug interactions which are to be considered when you give acitretin. When there is associated ingestion of alcohol, as we discussed previously, that it can be converted to etretinate, and that can persist in the body. There is interaction with glibenclamide. There is interaction with oral contraceptive progesterone preparations. When you give methotrexate and acitretin together, there is an increased chance of hepatotoxicity. It can reduce the protein binding of phenytoin. And acitretin, it's important to know that acitretin and tetracycline cannot be given together, as both increases the intracranial pressure. So a word on acitretin and pregnancy and nursing. Should not be given in patients who are pregnant or who want to be pregnant in the 3 years following discontinuation of therapy. And mothers receiving acitretin should not breastfeed the child, as it is secreted in the breast milk, but it is not a teratogen when used in males, in male patients who are potentially fathering a child. So there is no restriction as in the males, unlike that of methotrexate. Now, so these are the 3 important drugs that we use conventionally in the treatment of psoriasis. We are not going to the rare drugs like hydroxyurea. Sometimes they are useful when considering the various aspects, toxicities, adverse effects, comorbidities. We may be using hydroxyurea or sometimes mycophenolate mofetil and drugs like that. But we should be knowing in detail about the adverse effects, side effects, drug interactions, and all those things. And sometimes for getting a better control of the disease, we may give a combination therapy of drugs. Combination of drugs are given. A typical example is acitretin and PHARMA, retinoid and PHARMA, as already discussed in the previous session. It increases the effect of both drugs, or we can reduce the dosage so that and reduce the toxicity of each drug. And in the case of acitretin and PHARMA, another advantage is that acitretin reduces the potential for malignancy. So that will be useful in the treatment of PHARMA. So that is an important combination. We have to be very careful while giving combination therapy. Acitretin, as previously said, acitretin cannot be combined with methotrexate because of increased dose. Similarly, methotrexate cannot be combined with cyclosporine. And a combination therapy can be there with systemic drugs and topical drugs. We can combine both, and that can be used for the benefit of the patient. Another method of treatment is rotational therapy. We can give a drug for some time and then change over, maybe 1 or 2 years. We may manage a patient with methotrexate, and in order to avoid the cumulative toxicity of methotrexate, we can gradually stop and replace with another drug. Like you may add acitretin or PHARMA, so that we can reduce the toxicity of one drug and get a control of the disease. That is the rotational therapy. There may be a small overlap period between the 2 drugs during the rotational therapy. And the next method of therapy is a sequential therapy, where you give one drug. A typical example is you give cyclosporine for immediate control of the disease. And we know that we cannot give cyclosporine for a long time, or that it is not advocated for more than 1 year time because of renal toxicity. So once you control the disease, you can change over to a less toxic drug. For example, you may go for acitretin or PHARMA therapy. So that is a sequential therapy. So these are the methods which we should be knowing while managing patients with systemic drugs. So that is briefly about the conventional drugs in the treatment of psoriasis. I'll not be considering, because of lack of time, we'll not be considering the small molecules. Now I think we will go for the question session. Can I go for question answers?
Yes,
Okay.
madam.
Okay, carry on.
I'm sorry, I am plan it as a multiple choice question. I think you have to type the answer. So, how long should a patient wait before becoming pregnant after stopping Acitretin? Can I go to the next question?
Yes, madam. You can shut a second question.
Sorry, I'm giving the am I supposed to give the answer or?
Madam, I'll share the question. I mean, all the response to you via WhatsApp, madam. You can select and you can send to us, madam. Sir, correct answer will announce, madam.
So, I
Yes,
didn't
madam.
get it.
You can.
Shall I?
Yes, madam. You can. Madam, 1 minute. You can shoot questions first, madam.
I think I have the slides in questions and answers in that order. So I'm
Oh,
okay.
okay.
Let's wrap it.
Okay.
So the next
Then
question,
it is okay, madam. If you have in that way, question answer simultaneously, means
I'll
we can.
not go to the explanation of the
Okay.
answer. I'll just skip
Sure.
that.
Sure.
Okay. Which systemic drug can be used relatively safely for psoriasis in a patient with immunosuppression? Okay. Can I ask the next question?
Yes, madam.
What is the cumulative dose at which liver biopsy is recommended in a low-risk patient on methotrexate? Next question.
Yes, madam.
Which conventional systemic drug will you choose for a rapid control of acute flare-up of a disease? I think with that, my questions are over. Thank you very much for hearing me. Thank you very much.
Thank you, Professor Devi. This is a wonderful session. I think most of the postgraduates should know what Dr. Devi has said, and it is most of the time when facing a practical examination, the questions based on this talk will be asked, and examiner wants to hear the answers as Dr. Devi has said. So be careful with the talk. Register this talk in your mind, and just go ahead with the preparation. Thank you, Dr. Devi, for the excellent talk. And we will be expecting you, both of you, in the next few sessions also. So thank you very much.
Madam, the responses are sent to your WhatsApp, madam, one by one. You can select and send us, madam.
Once that is, when the speaker chooses the first prize winners, it will be announced immediately.
Sir, now you can announce the first 5 question winners, sir.
Okay.
Yes, sir.
Did you send it to my WhatsApp?
Yes, sir. It is there, sir. Once again, I'm sending, sir.
Okay.
Yes, sir. Now you can check it, sir. Madam, kindly stop sharing, madam.
In Dr. The previous talk,
Yes, yes.
and the questions are answered by the first question is Dr. Arul Mori Rajan, Tirunelveli Medical College. That is the first question. Second question, Dr. Megha Mary Alex, Amala Medical College. Third question is Dr. Pooja Reshmi. Fourth is Dr. Adira PV, Rengaraya Medical College, Kakinada. And fifth question, Dr. Narmada Armugan, Vinayaga Medical College, Salem. So these are the winners, and you will receive the prize shortly.
Dr. Pooja Reshmi, madam, is there, madam? Dr. Pooja Reshmi, madam, are you there, ma'am?
Yes, sir.
Madam, just tell me your medical college name, madam.
Belgaum Institute of Medical College, Belgavi, Karnataka.
Okay, madam. Okay, fine, madam. Thank you, madam. Thank you. Thank you.
So the second talk, based on the second talk, the questions are asked by Professor Devi. And the winners are, for the first question, Dr. Arul Mori Rajan, Tirunelveli Medical College. Second question.
Second question.
Winner is Dr.
Doctor, this is the first only. So for your reference, 1 second, waiting for madam's response, sir. Just 1 minute, sir.
Oh, sorry. I'm sorry.
Kindly requesting delegates and the
I'm
participants.
going to select. I think sir is.
Yes, sir.
Sir will be selecting the.
No, ma'am. No, ma'am.
winners.
You have ma'am. You have to select. It is sent to you, ma'am.
I think the first question, the full answer is given by J. The name is not there. JS. What I can read. Name, full name is not there. He has given the answer.
Mr. Naveen, you can.
Yes, sir. Madam, for first question is 3 years tetragonic, correct, madam?
Teratogenic, and this person has given the full answer that it is liposoluble.
That is Dr. Aishwarya Meenalakshmi, madam. Dr. R. Aishwarya Meenalakshmi.
Okay. Oh.
Madam, are you there, madam? Dr. Aishwarya Meenalakshmi, madam?
Yes, sir.
Madam, you are from which medical college, madam?
Chengalpet Medical College, sir.
Okay, madam. Okay. All the best, madam.
Thank you.
Naveen, you send the entire list and consolidated list.
Yes, ma'am.
So that we can.
1 second.
We can announce it. Yeah.
1 second.
Hello. Pardon? And okay.
Naveen, is it ready?
Sir, 1 second, sir. The madam is telling, sir. Just 30 seconds.
Okay, okay. Okay. I got it, got it. But the medical college, they haven't mentioned. Anyway, the following are the winners. For the first question is Jaswandi Shirodhar. Which medical college? I am not sure. Dr. Jaswandi is there or not? Identify your college. Dr. Jaswandi. I think.
Judge
Hello,
Jashwant.
sir.
Yes, sir.
Hello, sir. I'm
Yeah.
from KIMS Bangalore, KIMS Hospital, Bangalore, sir.
Okay, okay. Thank you. She is
Thank you,
from
sir.
KIMS Hospital, Bangalore.
Yes, sir.
Second winner, second question, Dr. Mekha. Which medical college are you?
Sir, Amala Institute of Medical Science.
Okay, right. Thank you. The third winner, third question winner is Dr. RR. Who is RR? Just identify yourself.
Hello.
RR.
Yes, madam.
Yeah.
Sir, Dr. Ramisa, Andhra Medical College, Visakhapatnam.
Okay, thank you, Doctor. Congratulations, Dr. Mekha. And the fourth question, and the winner is Arulmozhi Rajan. From which college are you?
Tirunelveli Medical College.
Which one?
Tirunelveli Medical College.
Tirunelveli Medical.
Oh.
Yeah. Congratulations, all the winners. And all the winners will receive the prize shortly, and your certificate will also follow. Thank you all participants. And I have to thank our speakers for the today's session, and extremely happy to hear most of my friends, and I myself have benefited with their talk. Thank you, Dr. Adikrishnan and Dr. Devi. Thank you. Over to you, Naveen.
Uh,
Naveen.
Thank you so
Yes.
much, Doctor. Thanks for giving opportunity for Easters Pharma. Doctors, kindly share this benefitable program to your other college and other to your colleagues also. The program will continue in all dermatology. We'll cover all dermatology topics from different faculties across India. So kindly make use of this program, and the certificate as well as the gift voucher, everything will reach you shortly, Doctor. Thank you so much for opportunity. Have a nice day to all.